Hi everybody, my name is Michael Holbrook. I am a Clinical Operations and Administration Fellow at the University of Cincinnati. Thanks for coming to listen to my talk on critical care documentation for the ED provider. From a definition perspective, critical care has two routes that merit its identification. Either a patient has an acute impairment of one or more vital organ systems, or there is the probability of imminent or life-threatening deterioration of the patient's condition. It is the complexity of the patient's care and the thought processes, interventions, and coordination of that care that merits a patient's chart being denoted as such. This critical care requires direct delivery of on-site care and can be billed by either a physician or other qualified healthcare professional, such as a PA or NP. From a clerical perspective, there are CPT codes that denote that a chart is billed as critical care. 99291 pertains to a chart that is 30 to 74 minutes of duration, and 99292 is billed for each additional 30 minutes of critical care. Oftentimes, when the critical care documentation arises, one of the things that can be most confusing is, does this case qualify as critical care? While there are broad categories listed that would qualify, it is not an all-inclusive list. If you were to Google around, there are various institutions and references that can be used as cheat sheets to help provide some framework. However, given the variability of medicine and the complexity and individuality of each person, it's difficult to create an all-encompassing list. The individual case depends on the patient, their medical history, the severity of their presentation, and the course that their care takes during the emergency department stay. It's really a matter of the thought processes, the interventions, and coordination of care that occurred that make the patient's care qualify as critical. What may be critical for one patient may not be for another. For example, a patient who is immunocompromised and septic, who in that situation would have two surge criteria and a UTI, is a bit different of an encounter than an otherwise healthy 25-year-old who has a urinary tract infection, tachycardia, and a 100.4 fever. What makes critical care documentation unique compared to the other CPT codes that are commonly billed for by ED providers is that critical care documentation is time-based. For other charts, there are requirements. Those have been changed starting in 2023. This is what you know as previously the HPI, review of systems, physical exam, however, has now been revised to involve complexity of problems, data, and risk. These will not be further discussed on this presentation, but will be available on a separate talk on the YouTube channel. All that is required for critical care documentation are three things: the amount of time, why the patient is considered critically ill, and the nature of the treatment and management of the patient. The chart below depicts the metrics by which critical care charts are billed. The intensity of the billing is based on the time spent on the case. Likely what you are thinking about is the CPT code 99291, as these are the cases where 30 to 74 minutes are spent on the patient and likely pertains to a majority of your critical care cases. Each additional 30 minutes merits application of a 99292 code. For example, a case lasting 2 hours or 120 minutes would be billed for under three charges: 99291 and then two 99292s, where the 99291 would be the first 74 minutes, the subsequent 30 minutes would be 99292, and the final 14 minutes would be the 99292 for the second time. Of note, care that is not 30 minutes should be billed for in the traditional manner with the new MDM rules as specified previously. The reason that time is a qualifier for critical care charts is that all activities are bundled into that charge. There are a lot of things that can be involved in the bundle, and this is a list of some of those things, such as reviewing the patient's history, either before they arrive or during their care, as you're trying to understand all the things that may have led to their care and their current presentation. Obtaining the history, performing the physical examination, ordering and reviewing labs, the reevaluation, discussions with consultants. This is all added up into the time spent on the patient. And one additional thing that may not always be thought of as time spent during critical care is the documentation. Because of how important understanding the provider's thought process is, there's weight given to its completion. One thing that's worth discussing is how to mental model family involvement into the time spent on critical care. Generally speaking, family can be counted towards critical care if it drives the care forward. It can be on the phone or in person. Oftentimes it counts when the patient is unable to participate for whatever reason. In this situation, families needed to help understand the treatment plans, goals of care, code status, procedural consent, etc. Things don't necessarily count if they are explanation of the situation, either initially or to repeat or later arriving family members. Other things that don't count are ongoing care updates that do inform the patient's family of the patient's condition. Generally, there are a lot of procedures that, when not performed as part of critical care, could be independently billed for, and these are listed on the slide. When they are involved in the critical care patient, they are not separately billed for. For example, if you are titrating a vent, the time spent performing that procedure is aggregated into the total critical care time. There are procedures that are separately billed for, and this is definitely not an extensive list. If these procedures occur for a patient undergoing critical care, the time spent performing this procedure would be mentally removed from the aggregate critical care time. CPR falls into the category of separately billable CPT codes, and that code is 92950. For example, if a patient arrives as a CPR in progress, and for the first 8 minutes they undergo compressions and then ROSC is obtained, and then the next 30 minutes are spent in the resuscitation bay due to subsequent hypotension and ongoing care of the patient, there could be 2 billing codes in this manner, the 92950 for the CPR and then the 99291 for the critical care, so long that the post-CPR involvement exceeds the 30-minute minimum. New to the critical care discussion in 2023 is the concept of split shared visits. This is when a patient is being taken care of by an APP in combination with the physician. And in this case, the individual that can and should bill for the critical care is whoever provides the substantive portion of the critical care time, which is defined as greater than 50% of the total time spent on the patient. So for instance, if 75 total minutes are spent between the physician and APP, if the doc has 35 and the APP has 40, it would be the APP whose documentation counts towards the billing. Now, there will obviously be situations where the 2 individuals are discussing the patient, and that time only counts as one allotment. For example, 10 minutes spent by the 2 of them does not count as 20 minutes. It counts as 10 of the total minutes spent on the patient. As the cohort of individuals watching these videos are likely at teaching institutions, it's worth discussing resident involvement in critical care billing. And simply put, residents cannot bill for critical care. Therefore, it's incumbent on the attending to document the 3 pertinent pieces of information that were previously discussed: time spent, why the patient is considered critically ill, and the nature of the treatment and management of the patient. Time that is being spent on the patient by the resident alone does not count as critical care, nor does teaching by the attendant count as a part of that critical care time. This concept is important to understand the monetary impact that good critical care documentation can have on your department. A little bit of background. An RVU is a CMS determined value of a service or procedure relative to all services and procedures. This is a measure of value is based on the extent of physician work, clinical and non-clinical resources, and expertise required to deliver healthcare services to a patient. For this conversation, a level 4 chart qualifies as 3.56 RVUs, a level 5 as 5.17, and critical care 6.33. There is also a conversion factor that adjusts based on economic factors and policies that is assigned per RVU that creates the charge of the procedure or service. Essentially, it's RVU times conversion factor for the charge. And roughly speaking, as you look at this slide, it's about $120 per level of service 4, $175 per level of service 5, and $215 per level of service of critical care per chart. As an example, if you're an institution with 80,000 patients and you miss 5% of your critical care patients, that would be, roughly speaking, around 4,000 patients. If they are billed for at a 4 or a 5 instead of at a critical care, this would be a loss of $157,000 to $375,000 annually. And one of the reasons why this is worth noting is that this is a change that does not need additional resources. No additional providers, no additional techs, nursing staff, equipment. No new supplies, policies, processes, nothing. It is just proper documentation of the care that is already being performed that would allow you to realize this otherwise lost revenue source. What are some pitfalls to critical care documentation? I think the first one is just not documenting. I would advise having a template or a hard stop. On a busy shift, it's easy to forget to bill for it, and so I think opting out versus opting in is the appropriate first nudge to increasing your group's volume of critical care charts. I would say not including minutes into the documentation is also a potential downfall, or not being specific about the amount of minutes. For example, a provider cannot document between 1 to 2 hours. It would have to be 91 minutes. As you saw previously, it is those specific aliquots in minute increments that is the metric by which charts are billed for. Another one is thinking that the patient needs to be in the emergency department for 30 minutes. So one situation that comes to mind for this is a pre-hospital STEMI. If you get an EKG that shows concern for saline-interletal STEMI, there's time spent interpreting that EKG, there's time spent activating the cath lab, there's time setting up the room in case the patient needs to be intubated, there is time spent calling pharmacy to get potential medications. All of that happens before the patient gets there, but it would still count towards time spent on that patient. And then if you add in the physical exam, understanding their history, and all the subsequent care in the emergency department, I think it's easy to conceptualize that a case that's not in the ED for 30 minutes could still have 30 minutes of critical care time. Another pitfall is just not thinking about all the time that's spent on the patient. Oftentimes we'll go see them and get interrupted, or in with another patient, and then we get a call from a consultant, and then we have to step into the hallway to discuss their care, and that time adds up. So thinking about all of the things that were previously mentioned on that bundled slide: family discussion, chart review, initial evaluation, reevaluation, documentation. This all goes to the next point of thinking that critical care also does not have to happen in critical care areas. So it's easy for us to think about patients who arrive to the resuscitation bay and have a dramatic arrival that necessitates critical care. However, just because a sick patient was mistriaged to your low acuity or fast track area doesn't mean that the patient's care is not critical. And along those lines, you can do critical care in non-critical care areas, such as when you're in the hallway, at your desk, on the phone, etc. All of that can be thought of as critical care, even if it's not at the patient's bedside. I think another pitfall is that thinking that care has to be consecutive. So for instance, oftentimes when you're going to a chart, you're thinking that you are involved in critical care, and one of the ways that we can use that metric is to go to the patient care timeline to see when they arrived and kind of guess around when you left the resuscitation room. But that method itself removes all the other things that we talked about, including the future calls and care and coordination. And so just thinking about all the time that's spent on the patient and not just that time spent at the bedside. One potential final example of not billing for critical care is that you can bill for care that is kind of not provided. For example, a patient presents for concerns of stroke-like symptoms. Pre-hospital, they had a positive Cincinnati FAST, so you activate a code stroke, you perform an NIH, you send them to scanner, you call the stroke team, you enroll all these powerful and expensive resources to properly evaluate the patient. If for whatever reason it was decided that the patient did not merit thrombolytics, and you were documenting all the thought processes and reasons for it, as well as the discussion with providers and consideration of the case, it could still count as critical care due to that second portion, which states that there is the probability of imminent or life-threatening deterioration of the patient's condition. So I think the takeaway more than anything is how simple critical care documentation is. It is what was done, why it was done, and the time spent on the patient. I would say that the first step, if your institution is struggling with critical care billing, is to incorporate a hard stop into the default provider note, making it an opt-out versus an opt-in. And my second hint would be to try to remember that it is accumulation of all aggregated time spent on the patient, on the phone, on the computer, and at the bedside. These are my resources. Thank you so much for your time.